You know, usually when you think about an orchestra, you picture harmony. Like every single instrument has its designated part.
Right, they're all playing together to create something coordinated.
Exactly, something beautiful. But imagine you're sitting in the audience and suddenly the cellist just starts playing entirely out of tune.
Oh, that's the worst.
Right, it's grating. But you think, maybe they'll correct it. Then the violinist speeds up completely out of rhythm with everyone else.
So it's just a complete collapse of coordination.
Yeah, before you know it, this beautiful symphony has turned into this chaotic, destructive noise.
You're left with a collision of sound instead of music.
And what we are diving into today is how your own body can undergo that exact same kind of chaotic breakdown. So welcome to today's deep dive.
Thanks for having me.
We're unpacking a massive, incredibly dense medical review from 2005. It's from the Postgraduate Medical Journal, and it's all about a condition known as metabolic syndrome.
Right, and we're focusing specifically on its hallmark feature, which is dyslipidemia.
Yeah, and in the medical literature, this syndrome is actually referred to using a rather grim synonym. They call it DROPI syndrome, or the deadly quartet.
The deadly quartet, yeah.
Which stands for dyslipidemia, insulin resistance, obesity, and high blood pressure. We really want to understand how these four distinct conditions basically gang up on the human body.
Playing that deadly quartet entirely out of tune.
Exactly.
What's fascinating here is that this syndrome, it represents the ultimate collision between our genetic predispositions and, well, the modern Western lifestyle.
Yeah.
Our mission today is to reveal exactly why our bodies react this way down at a microscopic level.
And the stakes for understanding this machinery are just incredibly high for you, the listener.
Let's put the stakes into perspective for a second.
Definitely.
Based on the 2000 U.S. Census data that's in the paper, an estimated 47 million U.S. residents have metabolic syndrome.
47 million, that's just a staggering number.
It is wild. And if you have it, you carry a 3.2 times relative risk of suffering an acute coronary event, like a heart attack. Right, so this isn't just rare medical jargon.
No, not at all. This is a massive public health reality. But before we get into the microscopic machinery of how this deadly quartet ruins the symphony, let's look at how researchers even figured out this is a lifestyle meets genetics issue.
Yeah, the population data.
Right. The data highlights a really striking real-world population study involving the Pima Indians.
Yeah, the Pima Indian population provides a perfect natural experiment, really, to understand the environmental triggers of this condition.
Because they have a shared genetic background.
Yeah. Exactly. We're looking at a group of people who share the same genetic background, but their environmental paths diverge significantly.
So tracing the history back about 700 to 1,000 years ago, a subset of the Pima Indians moved to Arizona.
Right.
And if you fast forward to modern times, that Arizona group has progressively adopted a Western diet and a largely sedentary lifestyle.
And the results of that shift are just staggering.
They really are. By the age of 35, over 85% of individuals in that group developed obesity. Yeah, and over 50% developed diabetes. But then you look at the other group of Pima Indians who stayed in Mexico.
The ones who maintained a more traditional lifestyle.
Right. Active farming, diets high in complex carbohydrates and fiber. And for them, obesity and diabetes don't even seem to be significant health problems.
So if we connect this to the bigger picture, it shows us that the pathogenesis of metabolic syndrome has multiple origins.
Right.
You have a population with a shared underlying genetic factor. You can think of it as a loaded genetic gun.
A loaded gun.
But the genetics alone don't cause the syndrome. It's the obesity, the sedentary lifestyle, the Western diet. Those act as the trigger pulling that gun.
Got it.
The genetic predisposition just leaves certain people far more susceptible to the metabolic disturbances produced by how we live today.
Okay, let's unpack this. Because reading through the definitions of metabolic syndrome in this paper, the criteria vary wildly depending on who you ask.
Absolutely. It's a point of contention.
Right, like the World Health Organization has one set of rules heavily focused on proving insulin resistance first.
Yeah.
But then the National Cholesterol Education Program, the NCEP ATP3, they have a totally different set focused on more accessible measurements, like waist circumference and fasting triglycerides.
Right, the clinical markers.
Yeah. So if these massive global health organizations can't even agree on a single definition, how do doctors even know who they are treating? Are we just slapping a scary label on people who eat poorly?
I mean, that is a very fair critique.
Yeah.
And its attention acknowledged right there in the medical community. The various cutoffs for what constitutes high blood pressure or too much belly fat have shifted over time.
Right.
However, the reason this clinical diagnosis is so crucial, regardless of which specific yardstick is used, is that it identifies elusive high-risk patients.
High-risk patients.
Right. When a doctor diagnoses metabolic syndrome, it tells them that the patient has substantial compounded cardiovascular risk. It's above and beyond just looking at individual risk factors in isolation.
So it's a signal that the whole system is connected and failing, not just one isolated part.
Exactly.
We're treating the underlying syndrome rather than just playing whack-a-mole with individual symptoms.
That is the core philosophy. We have to treat the root of the cascade.
Well, let's trace that cascade then. Let's move from the population level down to the cellular level.
Okay, let's do it.
We need to talk about the root cause of the syndrome's dyslipidemia, so the abnormal fats in the blood. And this basically comes down to what happens when our fat stops acting like fat.
Yeah, and this represents a major paradigm shift in medicine. Because for a long time, adipose tissue, what we just call fat, was regarded as a comparatively passive site of energy storage.
Just sitting there doing nothing.
Right. It was viewed as essentially just biological Tupperware, a place where the body hoarded extra calories in the form of triglycerides to use later.
But the data reveals that fat is actually an endocrine organ. It's an active gland.
It is actively communicating.
Yeah, it produces various proteins called adipocytokines. We're talking about signaling molecules like leptin, resistin, adiponectin, and tumor necrosis factor alpha.
And what happens in metabolic syndrome is a primary defect in this active tissue. The adipose tissue loses its ability to trap and incorporate free fatty acids into triglycerides.
Okay, wait.
The technical term is that it undergoes inadequate esterification.
Hold on. Esterification. Can we translate that into English?
Yeah, simply put, esterification is just the chemical process of binding those free-floating fatty acids into a stable, stored form.
So it's like a packing mechanism.
Exactly. It's the packing mechanism. When that process becomes inadequate, the fat cells just can't keep the energy locked away.
Oh, wow.
Furthermore, as insulin resistance sets in, it causes an even more profound inability for the adipocytes, the fat cells, to retain these free fatty acids.
I picture normal fat cells like a secure reservoir holding water, right? The water represents our stored energy. It's supposed to be a thick, secure dam.
Right, holding it all back.
But in metabolic syndrome, the dam is leaky. The fat cells just can't pack and hold on to those free fatty acids. And so all those fatty acids flood straight out of the adipose tissue and pour aggressively back into the bloodstream.
That leaky dam analogy perfectly captures the mechanics. And the consequences are profound. By acting as an active endocrine organ, the adipose tissue isn't just passively leaking energy.
What else is it doing?
It's actively sending chemical signals to the rest of the body. Those adipocytokines it produces, which all increase during obesity, by the way.
Except for adiponectin, right?
Right, with a notable exception of adiponectin, which actually drops. But the rest of them actively induce obesity-related insulin resistance.
That is wild. The fat is actively defending its own dysfunction. It's sending out hormones that make the rest of your body less responsive to insulin.
Exactly.
So we have this massive floodwater of free fatty acids pouring out of the leaky dam, and they have to go somewhere. They get swept up in the bloodstream and crash right into the body's main processing plant, the liver.
Yeah, and the liver is suddenly drowning in these free fatty acids.
So what does it do?
It has to manage this massive influx, so it tries to cope by doing the only thing it can. It turns them back into triglycerides and packages them into what are called very low-density lipoproteins.
Or VLDL.
Right, VLDL. And specifically, these large particles contain a structural protein called ApoB.
It's like the liver is a frantic shipping center. The conveyor belt of raw fatty acids just won't stop coming in from the leaky fat cells.
Just a continuous wave of them.
So the liver's workers are frantically stuffing these fats into shipping boxes, the VLDLs, and throwing them out the loading dock into the bloodstream.
Right.
Now, normally, insulin acts as the manager on the floor. It acts as a brake on this VLDL production, telling the liver to slow the assembly line down. But because the liver has become insulin resistant, it completely ignores the manager screaming to stop.
Yeah, the high insulin values are present in the blood, but the liver is deaf to its inhibitory effects. To understand how frantically these shipping boxes are made, cellular experiments suggest VLDL assembly is a rapid two-step process.
Okay, how does that work?
First, a small particle is formed in the rough endoplasmic reticulum of the liver cell. Then the bulk of the triglyceride core is fused to it in a second step.
Whoa, take me back to high school biology for a second. The rough endoplasmic reticulum, that's just the manufacturing floor inside the cell, right?
Yes, exactly. It's the cellular assembly line where proteins are synthesized and folded.
Got it.
So the liver is churning these particles out continuously. But the crisis compounds. Not only is the liver overproducing these large VLDL particles, but the body's ability to clear them from the blood drops simultaneously.
Wait, why does the clearance drop?
It's likely due to the decreased activity of an enzyme called lipoprotein lipase.
Let me guess, another casualty of insulin resistance.
Exactly. It's yet another casualty of insulin resistance. So the liver is frantically tossing full boxes into the bloodstream, and the delivery trucks that are supposed to take them away and empty them have all broken down.
That sounds like a disaster.
It is. The large VLDL particles just pile up in the blood, causing dangerously high fasting triglycerides.
Okay, so the bloodstream is now completely flooded with these VLDL shipping boxes. And this brings us to what happens to the specific cholesterol particles you always hear about at your annual doctor's appointment.
Right, the famous ones.
LDL, the bad cholesterol, and HDL, the good cholesterol.
And this is where the dysfunction in the liver cascades outward, destroying the rest of the lipid profile.
How so?
Well, because of the massive amount of triglycerides piling up in the blood, a specific transfer protein goes into overdrive. It's called CETP, cholesterol ester transfer protein.
And CETP's job is basically to swap things around between particles, right?
Right. It mediates an exchange. It takes triglycerides from those abundant VLDL shipping boxes and aggressively swaps them into the LDL and HDL particles, pulling out their cholesterol esters in return.
Wait, why would the body actively take triglycerides and stuff them into our good and bad cholesterol particles? That sounds like the body is actively sabotaging itself.
I mean, it does seem counterintuitive. Normally, CETP plays a role in a healthy balance, helping to shuttle cholesterol back to the liver.
Okay.
But in metabolic syndrome, the system is overwhelmed by the sheer volume of triglycerides. The CETP protein is just following its chemical gradient. It's trying to redistribute the massive triglyceride load, but in doing so, it corrupts the other particles.
So it's forcibly stuffing these triglycerides into the LDL. What actually happens to the LDL when it gets pumped full of fat like that?
That triglyceride-rich LDL becomes a prime target for another enzyme called hepatic lipase.
Okay.
Hepatic lipase comes along, digests the triglycerides out of it, and generates a new, altered, particle-small, dense LDL.
Here's where it gets really interesting. Because conventional wisdom tells us that a low overall LDL number is good.
Right.
But the clinical data emphasizes that even if your total LDL number looks perfectly fine on a lab report, having this small and dense LDL is terrible for you. Why is small, dense LDL so much worse than normal, fluffy LDL?
It really comes down to its physical and chemical properties.
Yeah.
Normal LDL particles are larger and more buoyant.
Okay.
But these small, dense particles fail to bind efficiently to the receptors that would normally clear them from the blood, so they circulate much longer.
That makes sense.
Worse, they have increased arterial wall retention and are highly susceptible to oxidation, which triggers inflammation.
I like to think of normal LDL like a beach ball. If you throw a beach ball at a chain link fence, the fence being the lining of your artery wall, it just bounces off. It's too big to get through.
Right.
But small, dense LDL is like a golf ball. You throw a golf ball at that same fence, and it slips right through the holes and gets permanently stuck inside the wall of your artery, building up plaque.
That physical analogy is incredibly accurate. They slip right into the subendothelial space of the arterial walls and become trapped. In fact, studies like the Johns Hopkins coronary artery disease study showed that measuring the sheer number of these particles by counting the ApoB proteins attached to them predicted coronary heart disease far better than standard LDL cholesterol levels.
Really?
Yeah. A massive percentage of patients with premature coronary heart disease had an overabundance of this specific dense ApoB protein structure.
So that's the bad cholesterol getting deadlier. But what about the good cholesterol, the HDL? You mentioned the CETP protein was also stuffing triglycerides into those particles.
Yes, and the result there is equally catastrophic, but in a different way.
How so?
The HDL particle gets pumped full of triglycerides, which alters its core structure and makes it highly unstable. It becomes depleted of its normal cholesterol.
Oh.
Because it's unstable, the main structural protein holding it together, called ApoA, begins to loosen.
It just falls apart.
It completely dissociates. And once that ApoA protein falls off the particle, the kidneys recognize it as free-floating waste and rapidly flush it from the body through the urine.
You literally pee out your good cholesterol.
Exactly. The consequence is that the patient is left with very low HDL cholesterol.
Which is bad.
Since HDL has vital antioxidant and anti-inflammatory effects, it's basically the cleanup crew for your arteries. Losing it accelerates cardiovascular disease exponentially.
Okay, so let's trace the domino so far. The leaky fat cells cause the frantic liver, which causes the golf ball LDL, and the disappearing HDL.
That's the chain reaction.
But everything we've mapped out up to this point is just happening in the fasting state of the body. These are the mechanics happening when we haven't eaten for 12 hours before a blood draw.
Right, baseline mechanics.
Let's look at what happens in real time when you actually eat a meal. This is a concept called postprandial lipemia, and it's the bridge linking metabolic syndrome directly to type 2 diabetes.
This brings up a critical metabolic stress test. How does the body handle an influx of new dietary fat on top of a system that is already malfunctioning and saturated?
Right.
When you eat a meal, your intestines package the new dietary fat into delivery particles called chylomicrons.
But remember, the liver is already frantically pumping out those VLDL shipping boxes because it's completely insulin resistant.
So now, the liver's overproduction of VLDL is competing directly with the remnants of your meal, the chylomicrons, for uptake by the liver's clearance receptors.
Oh, man.
The liver is simply too busy to process the new dietary fat. As a result, both the liver's particles and the meal's particles stay trapped in the blood for extended periods.
So if you think about a standard day, you eat breakfast at 8 a.m., lunch at 1 p.m., and dinner at 7 p.m. If your body is overwhelmed for hours after every single meal, you are quite literally spending almost your entire day in a state of toxic fat overload.
You really are.
You never get a break. The damage isn't just a static number on a fasting chart, it is actively compounding all day long.
That is the harsh reality of postprandial lipemia. Clinical observations show that in these patients, plasma-free fatty acid concentrations can remain significantly elevated for up to 8 hours after a meal.
8 hours.
The blood is perpetually saturated. And this prolonged exposure to high levels of free fatty acids produces a condition known as lipotoxicity.
Lipotoxicity, toxic fat levels.
Hi.
And what does bathing your organs in toxic fat do over time?
It is particularly devastating to the pancreas, specifically the beta cells that produce insulin.
Okay.
The lipotoxicity physically hampers glucose-induced insulin secretion. So the body's insulin resistance is already high, demanding more insulin, and now the pancreas itself is being damaged and struggles to produce enough to overcome that resistance.
It's a vicious cycle.
Over a protracted period, the pancreas exhausts itself and eventually fails to provide sufficient insulin for the metabolic needs of the body.
And that's when things break down completely.
Right. Blood sugar spikes, dietary glucose intolerance emerges, and ultimately you cross the threshold into full-blown type 2 diabetes.
Which is incredibly dangerous for cardiovascular health on its own.
To put it in perspective, about 80% of deaths among patients with diabetes mellitus are caused by cardiovascular disease.
80%.
The risk is so profound that major cholesterol education guidelines recommend treating patients with diabetes as aggressively as you would treat a patient who has already suffered a myocardial infarction, a heart attack.
Wow. If you have diabetes, medically, the prevention strategy is treated with the exact same urgency as if you've already had a heart attack.
Exactly.
That really puts the severity of this entire cascade into perspective. But with this grim reality fully laid out, we need to transition to some hope. The data does provide highly actionable solutions for reclaiming control of the system. Let's start with lifestyle interventions.
The lifestyle interventions are remarkably effective because they target the root of the cascade.
Right.
For individuals with visceral obesity, even just a 10% reduction in body weight significantly improves insulin sensitivity.
10%.
It reduces the physical mass of the visceral fat, which decreases the liver's fat production, and reciprocally upregulates the body's ability to clear that dangerous, dense ApoB cholesterol.
10%. You don't have to look like a fitness model. Just a 10% reduction starts physically repairing the cellular machinery.
Yeah.
And for physical activity, the data shows even moderate levels of exercise like walking for 30 to 45 minutes 3 or more times a week are incredibly useful.
It's about creating an energy sink.
Yeah.
Getting the muscles to utilize glucose actively reduces the daily burden on the pancreas and the insulin system.
And on the dietary front, there's a fascinating clinical note about omega-3 fatty acids.
Oh, yes.
Yeah, high-dose omega-3s. We're talking 6 to 12 grams per day, which you can get from concentrated fish oil supplements, or by eating roughly 9 to 12 ounces of salmon a day.
Right, a substantial amount.
The clinical results show this can slash serum triglyceride levels by a staggering 40% to 80%.
It drastically clears the triglycerides from the blood. And since we mapped out how high triglycerides are the primary driver for creating the small, dense LDL and destroying the good HDL via that CETP protein, lowering them by 80% is a massive victory for cardiovascular health.
But sometimes, changing the lifestyle just isn't enough to stop the momentum of the syndrome, which is where the pharmacology comes in. The medical toolkit outlines 3 major groups of lipid-changing drugs. We have niacin, fibrates, and statins.
Let's look at niacin. It is particularly fascinating because of how broadly it works.
How so?
It effectively treats almost every common lipid abnormality in the syndrome. Researchers discovered that niacin binds to a highly expressed G protein-coupled receptor located directly in adipose tissue.
In the fat itself.
Right. By binding there, it reduces specific cellular concentrations and actively inhibits lipolysis, the breakdown of stored fat.
In other words, niacin physically plugs the leaky dam in the fat cells we talked about at the very beginning. It stops the raw, free fatty acids from flooding out and overwhelming the liver.
That is the exact mechanism. Then you have fibrates.
Oh, well, what do they do?
These act on a specific nuclear receptor called PPAR-alpha, which is heavily expressed in tissues with high metabolic rates like the liver and heart.
Right.
Fibrates inhibit the liver from synthesizing new fatty acids and massively increase the catabolism or breakdown of those triglyceride-rich VLDL particles.
So if niacin plugs the leaky dam, fibrates act like a turbocharger for clearing out the shipping boxes that the liver already threw into the bloodstream.
Exactly. And finally, we have statins, which most people have probably heard of.
Oh, sure.
They block an enzyme called HMG-CoA reductase, essentially shutting down the assembly line pathway through which cells synthesize cholesterol in the first place.
Okay.
They lower the bad LDL and have been shown to modestly increase the good HDL.
Because these drugs target different mechanisms, doctors will often use combination therapy, right?
Yes. Using a statin with a fibrate or a statin with niacin to attack the syndrome from multiple angles simultaneously.
So what does this all mean? I look at this treatment plan like repairing a complex failing engine. You can't always just change the oil, which would be your diet and exercise.
Right, yeah.
Sometimes the engine is so deeply out of tune that you need specific tools to fix different broken belts simultaneously. You might need a statin to lower the raw cholesterol production, a fibrate to clear out the existing triglycerides, and niacin to stop the fat cells from leaking in the first place.
The comparative safety of these combined pharmacological therapies is quite good, though they must be managed carefully.
Right, there are always risks.
They're usually prescribed at low or moderate statin doses because combining them can increase the risk of drug-induced myopathy.
Real quick, myopathy, that's muscle pain and weakness, right?
Correct. It's a known side effect where the muscle tissue becomes inflamed or damaged, so patients have to be educated on the warning signs.
Good to know.
But the overarching takeaway is that modern medicine is truly beginning to understand exactly how these drugs work at a receptor level, like finding that specific niacin receptor in the fat tissue.
Yeah.
And researchers are pointing toward even newer frontiers, like CETP inhibitors.
Oh, to block that swapping protein.
Exactly. Drugs designed to directly block the protein that forcefully stuffs triglycerides into the HDL, offering a novel way to preserve and raise our good cholesterol.
It's incredible how detailed and precise the chemical warfare has to be to fight back against this condition. To wrap things up for you today, if there is one thing to remember, it's that metabolic syndrome is a multi-risk system.
A total cascade.
It's not just about getting one bad cholesterol number on an annual blood test. It is a massive, interconnected biological cascade. It starts from leaky fat cells that have morphed into an inflamed endocrine organ.
Which floods the liver.
Right. That leak floods a frantic liver, which churns out triglycerides. That overflow creates golf ball-sized LDL that gets trapped in your arteries, and it causes your good HDL to literally fall apart and flee your body through your kidneys.
And since we've learned today that adipose tissue is actually a complex, active endocrine organ constantly communicating with the rest of the body via adipocytokines, I want to leave you with this provocative thought.
Let's hear it.
What if the future of cardiovascular medicine isn't just about mechanically shrinking fat or blocking cholesterol production in the liver with a statin?
Okay.
Imagine a future where we develop therapies that actually talk back to our fat cells. therapies that rewrite those hormonal signals so that our fat actively protects our cardiovascular system instead of attacking it.
That is a wild thought. Turning the fat from a rogue enemy back into a cellular ally. If we can do that, maybe we can finally get that deadly quartet back in tune and playing a symphony we actually want to listen to. Thank you so much for joining us on this deep dive. Keep asking questions about the amazing, complex machinery of your own body, and we'll catch you next time.